like to welcome you today to our HiPEC Facebook Live event entitled Quality of Life After HiPEC with our presenter, Dr. Shanel Bhagwandin at Jupiter Medical Center out of Jupiter, Florida. Dr. Bhagwandin, before we get started, could you maybe go through a little bit about your background and the program that you have at Jupiter Medical?
Certainly. Thank you for the opportunity to speak to our audience today. My name is Shanel Bhagwandin. I'm a surgical oncologist. I'm board certified and fellowship trained in surgical oncology. And that is a little bit of my area of expertise with regards to primarily GI cancers. I trained at Mount Sinai in New York City in a fellowship for surgical oncology where I learned to do this procedure specifically. And I've had an opportunity to obviously bring that down to South Florida, to Jupiter Medical Center, to establish a program here where there wasn't one before. And then ultimately, we've been able to establish a high volume program for patients with peritoneal surface malignancies, which we're going to talk about today.
Okay. Speaking of peritoneal surface malignancies, could you explain the cancers that are treated with HiPEC and what is HiPEC?
Sure. So peritoneal surface malignancies just refers, it's the umbrella topic that encompasses all cancers that can spread this way. The majority of cancers within the abdomen can actually spread throughout the peritoneum, which is the thin layer or membrane that covers the abdominal organs and the surfaces within the abdomen. So a lot of organs and cancers can spread by way of depositing tumor cells on top of these surfaces and growing independently. HiPEC is a type of treatment modality that's utilized to effectively treat cancers that spread this way, but it is selective with regards to what type of cancers, because we know that some cancers are so aggressive that they may not respond to such an aggressive combination of surgery and chemotherapy. HiPEC stands for hyperthermic intraperitoneal chemotherapy, and it is used in combination with surgery to effectively eradicate cancer cells or tumors that are within the abdomen surgically. And then after all of the tumors and cancer cells are removed, we then apply chemotherapy and essentially perfuse it throughout the abdomen. That's the HiPEC portion of the procedure, to allow that chemotherapy to come in direct contact with any sort of residual cells that we may not see, that may be microscopic or not visible to the naked eye, to try to effectively treat these cancers and reduce the likelihood of them coming back.
Is this considered metastatic cancer or primary cancer?
In most cancers, this is considered metastatic, a stage 4 cancer. I didn't touch on the type of cancers as you asked before, but sometimes we often treat appendix cancer, which can spread this way. Primary peritoneal mesothelioma is a type of cancer that can start in the lining or that peritoneal layer. Other cancers that we treat with this is ovarian cancer, where when it spreads that way, it's considered stage 3. It is technically metastasized away from the ovary. But colon cancer, gastric cancer are considered metastasized when they spread this way, or stage 4 cancer.
Okay, can you take us through a little bit of how HiPEC works?
Sure. So the cytoreductive surgery and HiPEC is combined in a way that, again, we're working to essentially eradicate, kill all the cancer cells that we can either see on imaging, or, again, more so specifically when you're in the operating room, that are visible to the naked eye. So with the cytoreductive surgery or debulking, that aspect of the procedure is which all the gross visible cancer cells are removed. That may include the primary organ where the tumor originated from, say, for example, the appendix or the ovaries or the colon. We ultimately go after the primary cancer, where it originated from, as well as the metastasized cells. With the HiPEC portion of the procedure, that essentially means that with any sort of remaining microscopic cancer cells that need to be treated, and obviously they do need to be treated because otherwise they would lend themselves to that cancer coming back, the chemotherapy is circulated throughout the abdomen and it's essentially heated to work in combination to, again, get rid of any microscopic cells. That's done at the same setting, and it's only given one time. And following the procedure, that, or at least that concludes the procedure. once the surgery and the chemotherapy portion are done in conjunction.
Okay, who would be a candidate for this type of procedure?
Excellent question. So we have gotten better about selecting which patients are going to benefit. And again, as I touched on before, sometimes it often depends on the type of cancer, meaning where it originated from. This isn't something that we would offer for pancreatic cancer, for example, because of the nature of that disease and how aggressive it is. But what I will say is that it's clear that many physicians or even surgeons that treat cancer may not know or understand the procedure in its entirety because it's not available elsewhere. But in many instances, we do see patients that are told that there's not much that they can do. So a lot of it, again, is meeting with those patients, reviewing their imaging, their pathology to assess the biology, where the tumor originated from. And if that patient has a cancer that remains confined to the peritoneal cavity, which is essentially the abdomen, they can be a potential candidate to have this procedure, the cytoreductive surgery and the HIPEC. So I think it's important to have a consultation in that context to evaluate how much disease there is, what the biology is, make sure that the diagnosis is correct, and ultimately make sure that that patient would be able to go through a very involved procedure that would ultimately translate to improvement in survival.
So is there an age limit on this therapy as far as patients are concerned?
Not necessarily. We do know that a lot of the cancers that we treat nowadays are and do occur at more advanced ages. But a lot of it in terms of patient selection, again, is primarily dependent on how much disease there is. But of course, taking into consideration quality of life, especially with metastatic or stage 4 cancer, I think it's important to assess how that patient would be able to tolerate a very aggressive surgery and chemotherapy procedure before going forward with a more involved surgical approach.
Do these patients get IV chemotherapy in conjunction with HIPEC or just the HIPEC? And why would this be better than IV chemotherapy?
Excellent question. So there is a combination of that. I'll say that most patients that have stage 4 cancer, the standard of care is still traditional IV chemotherapy, where, again, chemotherapy is typically given through an intravenous route and it goes to those cancer cells. There are certain cancers that, and most of the cancers that spread this way, where the cancers have a poor or limited blood supply, so the chemotherapy effectively or ineffectively cannot reach them. So it's more difficult, for the IV chemo to reach those tumor cells. So although most patients will go through IV chemotherapy, the HIPEC that's given afterwards will then, and the surgery will then allow direct contact, meaning that the chemotherapy is coming in contact with those cells to, again, treat any sort of cells that may remain in the peritoneal cavity to kill them. So there is a combination. Usually appendix cancer is one in which where patients we know don't typically respond to IV chemotherapy if it's of a low-grade type. So that's a very important situation where the standard of care is to go straight to surgery and deliver the HIPEC chemotherapy. That is the standard of care in this country.
When should a patient come to see you? Which stage of the disease should they be looking for you?
I think I'm a big promoter of second opinions. So I think any cancer diagnosis, especially, sometimes does warrant that type of conversation. But specific to stage, I think when patients have an advanced cancer and they're noting either progression on chemotherapy, it's important to have those conversations about other treatments. Ideally, we would like to be involved, meaning surgeons and surgical oncologists that specifically do this. We would like to be involved at the beginning because, again, we do have an idea of how much disease there is and ultimately what needs to be considered to make sure someone can go through a procedure, or if they ultimately have unresectable disease, meaning that it can't be removed with surgery, that's a decision where we can have a conversation with the medical oncologist giving the IV chemotherapy so that they can plan definitively. A lot of the imaging sometimes does underestimate the amount of disease that's present within the abdomen. So I think it's also important to have that conversation up front and make sure that patients have a very thorough evaluation and the expectations are outlined, because especially with regards to surgery, and I'm sure we'll touch on the risks of the procedure, but it is a combination of multiple surgical procedures in one. So whereas you can have a portion of the bowel removed, the spleen removed, portions of the liver removed, it does combine multiple procedures to, again, effectively try to treat this. But the bottom line is that when patients are evaluated and they are deemed to be candidates, we know that HiPEC will increase survival time significantly.
Question coming in from our audience. This lady was diagnosed with adenocarcinoma of the transverse colon last October, 3 weeks after having a son. My colon ruptured and I had a colonoscopy placed. Went through chemo for 6 months and am now in ED. My surgical oncologist wants HiPEC. My oncologist doesn't agree. He said it's basically been a year. I'm confused as to what to do.
I think that's a very common situation, particularly when we see cancers perforate. That specific example does speak to how these tumors can spread, because again, you're describing a situation where a mass grows through the colon, ruptures, and as a result of that, it does gain access to the abdomen. I think that it's a very important treatment option, especially if what's described is that you've gone through systemic chemotherapy, IV chemotherapy essentially, and the disease has either stayed stable or it's amenable to doing a HiPEC procedure. That should be strongly considered. That's a situation where chemotherapy alone typically does not lend itself to cure or removing the bulk of disease. But with regards to utilizing the chemotherapy, the IV chemotherapy, and then subsequently perform a surgery, which sounds like has been recommended by the surgical oncologist, that's a situation that should, in my opinion, absolutely be entertained, because it is something that's going to remove any sort of residual tumor. But ultimately knowing, again, why there's that, let's say, this disagreement with regards to outcomes is one of the key reasons that a program needs to exist, so that these conversations can also occur in a multidisciplinary conference, so that again we can share our opinions and impressions about how to effectively treat this type of disease, but more importantly personalize that care to that specific individual. So I do think that is something that should be further entertained based on what's described.
Another question from our audience. Does HiPEC chemo kill the metastases in the small bowel?
So with regards to the chemotherapy, the idea is that, again, it's circulating throughout the abdomen and it's coming into contact on the surface of the structures. So if there are microscopic cells that are lingering, the idea is that it should come into contact with that. The chemotherapy isn't necessarily perfused through the small intestine, if I'm understanding that question correctly. So in a way, if someone has a tumor within the small intestine that may be shedding cells inside, if that's the thought, the chemotherapy won't necessarily come into contact with that. And although we can see what we call multifocal cancer, where deposits do occur along the length of the small intestine, is that's not typically the case where it happens inside, where a new cancer develops just by virtue of a tumor shedding inside of the intestine as opposed to external to it.
Another question coming in from our audience. When would you decline HiPEC? Excellent
question. I was trained by a lot of my mentors, especially with regards to this procedure, is that it's not only important to know when to do a procedure, but when not to do it, because 80% of the patients that we evaluate and treat with cancer that spreads this way, unfortunately, they can't have an operation. It's the small percentage of patients that have a low volume or burden of disease throughout the abdomen where it would make sense to go in and do something radical, meaning remove all of those tumor cells. So again, patient selection is key. And that's ultimately the answer to the question, is when there's a significant amount of disease throughout the abdomen, that it would preclude us from being able to safely say that we can remove all of the tumor, meaning that when we come out of the operating room, the idea is that all of the tumor that was visible has been removed. The second thing is that if that cancer has also metastasized to other organs outside of the abdomen, that's a reason that we wouldn't necessarily proceed with HiPEC, because that's a treatment that's guided primarily towards the abdomen. And if for some reason that cancer has spread to the lung, or sometimes even occupied inside of the liver, it may not make sense to proceed with a procedure like that, and it's typically not recommended in that setting. I think going back to patient selection, not every patient can tolerate a procedure like this. So a lot of that does mean that face-to-face conversation. Most patients have already gone through a surgery potentially for their primary cancer, so as well as IV chemotherapy. So a lot of that does speak to how well and how we can assess whether or not that treatment would be prescribed in that setting to again have another operation or an opportunity to do something effectively.
Another question coming in, what about laparoscopic HIPEC? Where's that fit into the procedure?
Excellent question. So when I was at Mount Sinai in New York City, we were able to have several patients undergo laparoscopic HIPEC. A lot of that, again, speaks to the low burden of disease, meaning that what you have to do surgically. We can deliver the chemotherapy through laparoscopic incisions, through the same sort of perfusion catheters. A lot of it does speak to just making sure that we can adequately see the extent of the abdomen laparoscopically. So we don't want to miss tumor, because laparoscopy, again, is introducing a camera in and taking a look around. But there's certain areas that can be difficult to get to, meaning behind the liver, behind the spleen, those types of things, are deep down in the pelvis. Ideally, we should be able to do that. But I will say that laparoscopic HIPEC is something that with a limited amount of disease is successful. In the time that I've been here, we've been able to do the first robotic HIPEC, and that's probably a procedure where there's only a handful within the state of Florida that's been able to do that. But again, it does speak to knowing that there's a limited amount of disease that we would be able to achieve that successfully surgically. Giving the chemotherapy and the HIPEC is not usually an issue doing that laparoscopic, because the abdomen does collapse for that portion of the procedure, where even though we're putting in fluid, it's not that the added air laparoscopically would create much of an issue.
Is a laparoscopic HIPEC done as a primary surgery, or is this recurrent disease?
Excellent question. So what I'll say is sort of answer two questions. One, I don't think that you've asked, but a lot of it is how we can also assess how much disease there is. So before we start the more involved operation, we typically put a camera inside and take a look around. And that also gives me an idea of how much disease there is within the abdomen to make sure that it is consistent with what we see on imaging. So during the primary operation, we usually put a camera in, again, assess, and then if that's the decision, we go forward with opening and doing the more involved operation. With regards to if it's done in the primary setting or a recurrent setting, usually it's done in the primary setting because there's a limited amount of disease. And sometimes if there's no visible disease and you're just delivering the chemotherapy, that is a situation that would benefit from laparoscopic or a laparoscopic approach. If the cancer does come back, and let's say someone has had a more extensive debulking through an open operation, I will say that it is limited. Laparoscopy in particular, it is limited to be able to, again, adequately assess the abdomen, and a lot more difficult, meaning that you're not getting into the spaces that you need to with the camera to adequately assess that. And sometimes, at least in my hands, I think it makes sense in that situation, if we don't see an abundance of disease, but to be able to safely look at everything and make sure we're effectively treating everything, sometimes that's best done through an open incision.
Okay. Next one is not a question, but a comment, obviously, from a patient that you treated. And I'll read it. Dr. Bhagwandin is an excellent surgeon, caring in his treatments, and a great communicator during the steps of determining your treatment. Works well with other physicians. Very nice comment. Very nice comment.
Thank you.
Another question. What kind of dietary restrictions can you expect after surgery?
You said after surgery, correct, Lynn?
Before and after.
Oh, before and after. So Excellent question. What we have looked at specifically prior to surgery, a lot of patients do have issues with bowel function, malabsorption, the anticipated weight loss, particularly if they're undergoing chemotherapy. So we try to optimize that as best with our oncology dietitian as well as our nutrition team to help just optimize patients. There's no specific dietary limitation prior to. Post-operatively, a lot of it does depend on what we end up doing through the surgery. So if we end up having to do any specific bowel resections, things like that, those are areas where we may modify the diet. Most of our patients end up eating solid food after surgery. It's just that we end up modifying the diet so it's less bulky, things like that. But ideally, I think nutrition is a key component to not only recovery, but pre-operative optimization. I will say that there's not a lot of specific dietary limitations that would necessarily make a difference one way or the other. Ultimately, when we talk about quality of life and what we've done with a lot of other different different surgeries that I do, namely esophagectomies, pancreas surgery, things like that, is that we've looked at what we call enhanced recovery pathways. And those are things that we're looking at implementing with HiPEC in terms of an evolving protocol where we recognize that patients ultimately will have lower risks for complications, improved quality of life. And two of the main things that happen with that is if they're fed early, meaning that we don't necessarily need to wait for patients to start to have bowel function, pass gas, things like that, but we advance the diet pretty quickly and minimize the use of NG tubes, which are decompressing the stomach. And those things do show that patients do regain bowel function faster, and as a result of that, they stay in the hospital fewer days than those that are not. So although that does translate again to some of the dietary questions, what patients have taught us essentially that do this operation is that they can recover faster, that we don't need to clinically make the decisions that say, well, you're now having bowel function, so let's advance your diet, is that we can allow that patient to trial the diet a lot faster and not limit them, so to speak, because it is a key component to how they recover.
Okay, another question coming in. How long will it be before I feel normal again after the HIPEC and surgery?
Sorry, did you say home again?
No, how long will it take before the patient feels normal after going through
normal.
the HIPEC?
Excellent question. So obviously we don't want to make the treatment worse than disease. What we do recognize is that quality of life is an important component to, let's say, undergoing a procedure like this. So what we want are acceptable results of symptom relief, because a lot of patients have pain, bloating, distension, and ultimately survival. But at the end of the day, looking at whether or not there's a risk reward there with regards to undergoing an extensive procedure. So a number of specialized centers have focused on quality of life, which really is where we get that information about how patients, one, define quality of life or normal, but ultimately get them back to their pre-operative baseline. And in most cases, I'll say that patients not only do achieve that baseline, but they can oftentimes have higher or better quality of life. A specific answer to that is that after surgery, most patients will have a recovery period, typically about 6 to 8 weeks. That doesn't mean that they're necessarily limited in terms of functionality, etc. There are certain deficits that we do see in terms of physical well-being, but with regards to being home, ambulating, meaning walking around, being active, those types of things, patients usually get to about 60 to 80% of their baseline by 6 to 8 weeks after surgery. Overall, and getting back to, let's say, their quality of life prior to surgery, and again, that's taking into consideration someone that may be on chemotherapy at that point, is that it's usually typically in the range of 3 to 6 months after surgery where patients start to notice that their quality of life has improved significantly. And I know that's a wide or a window there, but again, it's in terms of getting to that sense of looking at things like not only physical well-being, but their emotional states or emotional well-being, knowing that they've just dealt with a diagnosis or potentially a disease relapse, meaning that it's come back, and that fear, the anxiety of that, all of those things are taken into consideration when I say the 3 to 6 month window.
Speaking of recurrent disease, there's a question coming in from a patient over in the UK, 38-year-old male. had recurrence disease in the peritoneal from bowel cancer, which was removed but spread to the line. Had HIPEC a year ago. Is stable now on a chemotherapy. They were told by the surgeon that it would be too risky to do another HIPEC.
Right. So a lot of it, as long as things are stable, sometimes that decision sort of makes itself, meaning that going back in and doing a more aggressive operation, especially the second time around, may lend itself to significant complications, especially if it's obviously the same surgeon that did the procedure. I think that is always notable feedback in that you want to avoid a situation where if there's going to be an extensive procedure or a secondary procedure where that patient ends up with a prolonged hospitalization, if things are stable now and being that there's a tolerance of chemotherapy, sometimes it makes sense to continue that along that route as opposed to a prolonged hospitalization or even potentially death from a more aggressive operation based on what would be anticipated. The potential for ostomies, which are bags that patients can wear on the skin, ultimately can go up with the number of bowel resections. And again, from a quality of life standpoint, I think that's a key discussion with regards to the patient and their surgical oncologist about when is the opportune time to do that if things are stable or they're showing some degree of stability without progression.
Okay. Doctor, in closing, can you address the quality of life after HIPEC? And secondly, what is the advantage of a patient having cytoreduction surgery and HIPEC at Jupiter Medical with you?
Thank you. So peritoneal disease is often heterogeneous. Again, multiple diseases that we treat. There's no standard algorithm of care. So we do try to manage and treat patients individually. That's a little bit of my philosophy and how I was trained, especially here at Jupiter Medical Center since we've developed the program. And a lot of it, again, is looking at the patient's disease as well as their risk tolerance. It's specific to every individual. So we want to emphasize that shared decision making and obviously carefully counsel patients. When we talk about quality of life, again, a lot of it is trying to ensure that patients ultimately get back to what their baseline was. There are many different subscales and there are many different ways that people define quality of life. Some of it is, again, physical well-being. So things like pain, people define quality of life as not being in pain primarily, but dealing with persistent nausea, fatigue, just being in bed all the time. Those are things that we look at after an extensive procedure like this. Other things like social family well-being doesn't necessarily change after a procedure like this, but it is important to note that when patients have, let's say, unsatisfactory social family dynamics, meaning that the absence of relatives or a supportive environment, those are things that ultimately relate to quality of life and do persist afterwards. Emotionally, anxiety, just being sad, nervous, the risk of something coming back is a very real aspect of quality of life, and it can certainly contribute to the outcome of the operation. More importantly, functional well-being, enjoying life, just going back, if people work, going back to work, those things are expected. And overall, what we expect with regards to quality of life when I recommend a procedure like this, again, is it's not so much the survival benefit, which is key, but it's including that in our shared decision-making to ensure that we can achieve those things. To sort of sum up and say the things that we do see related with an improvement in quality of life, primarily patients that are of younger age because they do recover quicker, patients that have less disease or what we call a lower peritoneal carcinomatosis index, so they have less disease scattered throughout the belly, the ability to achieve a complete removal of all the tumors is certainly associated with an improvement in quality of life, and these things have been studied. As far as the presence or absence of an ostomy, which are things that we talked about, anytime we do these operations, that does affect quality of life adversely for obvious reasons. And, with regards to what we look at in terms of an enhanced recovery pathway, I think those are things that we've recognized that do improve quality of life with other surgeries. And as a result of that, especially with many of our patients, the goal here is to give them, again, the gift of time to improve not only their survival, but do it in a way that it lends itself to improve quality of life. So a lot of our patients, and my patients in particular, have told me that being the ability to be off of the IV chemotherapy for a significant amount of time, as well as several years out without any evidence of cancer, is ultimately how that translates. So I think with metastatic disease, with cancer that spreads this way, sometimes, and what's commonly recommended, is just definitive IV chemotherapy, and ultimately the survival that we know associated with that in most patients is roughly about 6 to 12 months. But being able to use the IV chemotherapy and then ultimately do a more definitive procedure can again translate to what we aim to do here at a program like Jupiter Medical Center, which is not only treat the cancer to improve survival beyond that what's quoted 6 to 12 months, but more effectively get patients to a point where they're off of chemotherapy, where they have no disease, and essentially enjoying life. So, we treat the breadth of cancers that spread this way: appendix, ovarian, again, peritoneal mesothelioma, colon and rectal, as well as some select patients with small bowel, as well as gastric cancer. But I think it's a very key component to how we select our patients. The multidisciplinary approach that we have here at Jupiter Medical Center is important because we're the only program on the East Coast where outside of Miami, we're seeing the volume with regards to this region, and to be able to provide care, offer that counseling, or even by way of telehealth consultation, provide second opinions and review imaging and pathology to ensure that patients are getting the correct treatment, diagnosis, and ultimate recommendation, because at the end of the day, it has to be personalized in that way.
Dr. Bhagwandin, I want to thank you very much for your presentation and the answers to the questions that came in from the audience. And audience, I'd like to thank you for your participation also. Have a good day, everybody. Thank you.
Thanks, Glenn. Thank you for the opportunity.